CataractCoach.com. Surgery for a cataract surgeon. Which IOL would you choose for your own eyes? This is the complete cataract case from start to finish. This is a surgeon who wishes to have cataract surgery for his own eye now. And so this doctor has done thousands of cataract surgeries on his own and certainly knows what he wants. The nice part is in the pre-op examination, when you talk to the patient, you can say, okay, here's what we're going to do, and let's look at the lens calcs together, and what do you think we should implant? And you can agree upon an IOL power as well as an IOL design or model ahead of time. Here's the incision I want to show you. I use a nice diamond keratome, barely nicking limbal vessels, getting a right tunnel length that is just about perfect. So we want to have that nice astigmatically neutral incision. You can see the tiny bit of bleeding there at the limbal vessels makes me happy because I know that's going to seal beautifully in the long term. I like slightly to nick those limbal vessels. I don't like a totally avascular incision in the cornea because that never heals. Let's get the Rexis. Now I'm measuring very carefully. As you know, every cataract surgeon wants a perfect Rexis for his or her own eye. In fact, all our patients want this. So we'll make that Rexis. We're going to aim for about a 5 millimeter Rexis. And we're going to put an optic on the IOL that has a diameter of 6 millimeters, so it'll overlap beautifully. Notice I'm also centering that Rexis on those Purkinje images. So we want that lens to be beautifully lined up with that visual axis. That's great. That's why the Rexis is made in that manner. A little hydro dissection here, nice and easy. Good fluid waves going across it. Tap the center. Let's try again. Let's see if we can spin the nucleus. And we'll go the other direction. And we'll tap the center of the nucleus again, and let's see if it spins beautifully. Remember, like I always teach, if it does not spin, you will not win. But this one spins nicely. A little extra viscoelastic there to protect those central corneal endothelial cells. We're going to go in with the PhacoPro bevel down chop technique here. Here we go. We're going to buzz right in the center of that nucleus in the subincisional space. Chopper goes in, and there you go, 2 halves. And now take our time to really spread apart the 2 heminuclear pieces, holding one at bay with the chopper, bring the other one up. You can see a little baby chop being done there on that first heminucleus, and we can certainly emulsify it and further sub-chop it. Now, this isn't too bad of a cataract, a moderate degree of nuclear sclerosis. Of course, cataract surgeons don't want to wait so long for their eyes. They know to have surgery when they're just starting to have these visual symptoms. So removing that first half very nicely, going into the second half, we'll buzz into it here, bring it up. I think chopper's going to go around. There it is, another chop. Split that into smaller pieces, and we'll emulsify those down. Goes without saying that we have very good, clean draping here. All the lashes out of the way. The lid margin is sequestered. There's no oil on that tear film at all. Nice and clean. Chopper in that safe position just to make sure. And we'll get the last bit of nuclear fragments out. There it is. Time for cortex removal. Now, this surgeon chose, surprise, surprise, a monofocal IOL, of course. Ophthalmologists, we value image quality number 1. And so this patient wants the best image quality and is okay wearing spectacles for whatever else. And in that regard, we're going to put a monofocal lens in. So we're asking what lens he liked, and he chose a specific model, which I'll show you here. It's going to be the Technis ZCB00, single-piece acrylic lens. And that's going to be a very appropriate choice for him here. Removing the rest of that cortex, we're going to also clean up that capsular bag a little bit better. We're going to polish that capsule. We'll clean up the undersurface of the anterior capsular rim. We'll get all that material out, all the lens epithelial cells. Here we go, nice and clean. We want to deliver a beautiful result for this fellow colleague. And so cleaning that up nicely, my technician's loading up our lens. Again, anesthesia here. The patient got just a little bit, 1 or 2 milligrams of Versed, which is midazolam in the intravenous line, given by our anesthesiologist. The eye was numb with just tetracaine, and then you saw at the beginning of the case, we put in some preservative-free 0.5% lidocaine inside the eye. That was 1% lido cut 50-50 with bowel salt solution. Filling in a capsular bag here, there's that Rexis, good-looking Rexis. I'll take it. Here comes the lens, single-piece acrylic going in the capsular bag. Nice and easy. And we'll get that delivered in and placed just where we want it. Now, this patient had a very minimal amount of corneal astigmatism, so no limbal relaxed incision was needed, so we're not going to do that here. Let's open up the haptics, get that lens in the position that we want. Let's get it oriented, and then we can get our probe in the eye and remove the remaining viscoelastic and call this day. So nice routine case, nothing out of the ordinary. I really enjoy operating on fellow ophthalmologists. It's a big honor for me, and I really aim to give this super high level of care and precision to all my patients. I'm like you. That's why we watch these videos. We make these videos because we really are passionate about what we do, and we love cataract surgery. So cleaning that up, there you go. Lens nicely positioned. Look at that Rexis overlapping it just beautifully. And sealing up that incision. We'll go back and forth here and hydrate that nicely. Now the incision seals beautifully on its own. We don't have to do too much hydration. And now let's do a little bit of an angle sweep, make sure that lens is in the position we like, and make sure there's no retained viscoelastic in the eye. We're squirting around here, a little tiny bit of viscoelastic. We'll get it all washed out. And then we'll finish this up. Let's do a little bit more just to make sure there's that little tiny bit of viscoelastic. By doing this technique, you really avoid any pressure spikes on post-op day one. They look great. Oh, it's fantastic. Put some medicine in the eye. Here's a little bit of preservative-free triamcinolone, just a little bit. In this case, only about 0.3 milligrams. And we'll swirl that around and then put a little small amount of preservative-free moxifloxacin as an antibiotic. There's the moxifloxacin going inside. And then now let's check the incisions, make sure they're all completely watertight. There's a sponge soaked in tetracaine, and now the dry sponge, and they look great. Thanks for trusting me with your eyes. I sincerely appreciate it. Thanks for watching these videos. And remember to go to CataractCoach.com and sign up for a free daily email. We'll send you an email every day with a great video like this and other surgical pearls that'll make you a better surgeon.